So at the outset, I extend my sincere thanks to the organizing committee of Midterm Scientific Meet of AOP Gujarat, especially to my friend Dr. Mehul and all the organizing team members, scientific committee members. And my special thanks again for giving me a perfect panel where you have a senior experienced practitioners, you have people who are always advocating for the antimicrobial stewardship. So I won't take much time in giving their introduction. We all know Dr. Manish Mehta, who is a practicing pediatrician at Ahmedabad. Of course, more in the intensive care, uh, and he is also our executive board member at the Central IAP. Dr. Baldev Bhai, my teacher, કાલે સાહેબને વાત કરી કે એકલવ્યની જેમ સાહેબ પાસેથી રિમોટલી બહુ જ શીખ્યા છે, હજુ બી શીખીએ છીએ. સો બળદેવભાઈ સર, then my best friend Dr. Abhay bhai, my buddy in ID chapter, and then not last but least our son of the soil, Naresh bhai. એકદમ મૃદુ વ્યક્તિત્વ પણ ખૂબ જ જે કહીએ ને ટુ ધી પોઈન્ટ વાત કરવાવાળા વ્યક્તિ. સો રિયલી થેન્ક ફોર ધ giving me the best panel. And in the earlier two sessions, we discussed about the things which we are not encountering that commonly in our clinical practice. But here in next 40 minutes time, we will be discussing mainly on certain common infections which are community acquired and how best we can choose the antibiotics empirically. I have about 8 cases in the presentation, and with cooperation of my experts, I wish we can complete all the 8 cases because we want to pass on the message related to this common conditions to the audience. So I request all the experts to be very brief, crisp answers and clear answers. And I also won't take much time in So, friends, we all know that most of the time when you have the diagnosis and when you start the antibiotic, it is called as a definitive antibiotic therapy. So, you have a microbiological diagnosis and you know that the XYZ is the bug, and you start the antibiotic targeted to that particular agent. But when you don't know the organism and when you are starting the antibiotic as a guess, the guess could be your clinical experience, guess could be your information about the ongoing epidemiology of a particular disease, and you start the antibiotic. That is called as a empiric antibiotic therapy. And then there is a third variety of antibiotic therapy, that is a prophylactic antibiotic therapy, which you start in usually not that prophylactic that a baby who is admitted to the NICU and you start the antibiotic. But then there are certain conditions where the person is at risk of getting the infection and you start the prophylactic antibiotic. So these are the three different varieties of antibiotic therapy. And okay, no issue, no issue. And just to recap about the definition of empiric antibiotic therapy. So the antibiotic therapy or a community acquiring infection is the infection which somebody gets when the person is not, the patient has not recently been in the healthcare facility or has not been in contact with someone who has been recently in the healthcare facility. So purely from the community. So with this background, let us move on to the case one. It's a case of a story of two different cases. A first case is 3-year-old male child comes with a fever of 101 degree, severe throat pain. There is a coryza for 2 days, multiple vesicles on the with the erythematous base on palate and tonsils. Similar illness in the elder brother at 3 days back, and no tender anterior cervical lymphadenopathy. And there is another case, a 8-year-old boy, persistent high fever, throat pain, taken treatment in form of azithromycin. The examination finding shows throat is congested and there is a tender anterior cervical lymphadenopathy. So, Dr. Manish, what will be your management principle in both the cases? Will it be same? Will it be different? If it is different, why?
Good morning, everyone. Can you move to the previous slide, sir? Yeah. So this case one, each and every sentence in this history is very important. Age of the child 3 years. History of coryza is there. There are multiple vesicles, and there was similar history in the elder brother, and there are no cervical lymph node, tender cervical lymph node. So all these favor in more of a viral infection rather than
Absolutely.
bacterial infection. We all know modified central criteria or MAC-ISA criteria,
Right.
which cover 5 points. There is presence of fever more than 101, age criteria that is 3 to 15 years. There is tender cervical lymph node, exudate on the tonsil, and absence of cough. So these 5 criteria match here as more of not investigating as well as not treating this child with antibiotic.
Right. So
And
basically, you mean to say that this is the case of viral pharyngotonsillitis.
Probably we are going to see lot many cases next few months, upcoming months. This type of
Okay.
patient.
And what about the second one?
And this second child fits into the criteria of acute bacterial tonsillitis, and obviously azithromycin given, which is not at all a drug of choice for this type
So
of
what
condition.
what you would have started?
So amoxicillin with 40 milligram per
Why
kilogram per day.
amoxicillin? Why and
So-
how many days?
Yeah. So most common cause is group A beta hemolytic
So
streptococci.
do you need to give the antibiotic for GBS?
Sir, yes, to prevent morbidity like
Suppurative
rheumatic fever. Yeah,
complication. So basically, I think Manish has made it very clear. The first case scenario is a very common scenario which we all pediatric GP practitioners come across, that is upper respiratory viral pharyngotonsillitis, and in these cases usually they are in the seasonal pattern, and there are several cases maybe in the family. The constitutional symptoms will be more, cough, cold will be there, coryza will be there, multi-system involvement will be there, and the central criteria what the Manish told, that these criteria, these are the like fever, tonsillar exudate, absent cough, anterior cervical lymphadenopathy. But please remember, it has a more negative predictive value than the positive predictive value. So if you have score which is favoring, then only you have to start antibiotic. Otherwise, so this is basically for the antimicrobial stewardship, and even for intervention, like whether to investigate or not, that also you will be deciding based on this modified central criteria. I think I won't go into the detail about this algorithm. We have discussed about that. Yes, sir. Sir, please.
I think only one important message with these two cases. We are not against the antibiotics, but that is very important the stewardship.
Stewardship.
If it is indicated not to these also failure. I think when second case what Dr. Manish was discussing, that if the streptococcal and really if he miss it, the late complication you may get either the rheumatic or the glomerulonephritis is also failure.
Yes.
So the point is, decide exactly if it is viral, there is no need. But if it fulfills the criteria, don't miss
Okay.
even. That is very important.
Right, sir. So again, that's what we expect from Dr. Baldev by when he is there in your as expert in the panel, that he will remind us the most relevant message. So again, the center criteria and all these things, they will be helping us when to start or when to investigate this patient. Otherwise, by and large, as I said, most of us, when you are getting it in a epidemic form, these are the viral infections, and you don't need to do it. Is just a purely symptomatic therapy. For bacterial, again, your basic purpose is to prevent the suppurative complications, and for that you need to have a adequate 10 days therapy. Another case, 15 months old child, fever, excessive crying, Fortunately, the pediatrician has the habit of keeping the otoscope and doing the otoscopy. So on otoscopy, he found red bulging tympanic membrane. There was a loss of cone of the light reflex. So Abhay bhai, what will you do in this case?
Yeah, so good morning, everybody. So it's a clear-cut case of acute otitis media.
Hmm.
And you see the otoscopy is the order of the day. The diagnosis of otitis media is a otoscopic diagnosis. Of course, the clinical presence is very important, but otoscopy is a must. That is the most important message that I want to drive. Second thing, look at the age of the child. What is the severity of disease?
Yes.
And whether the disease is unilateral or bilateral.
Yeah.
I think these three factors are very important to start the antibiotic therapy. Of course, the drug of choice is going to be either amoxicillin or amoxicillin, depending on the.
Why either of these? What organisms you suspect for the AOM?
Yeah, so we need to cover Streptococcus pneumoniae, H. flu, and Moraxella catarrhalis, and at times Staph aureus. But commonest cause is the Streptococcus pneumoniae.
Right.
Sometimes the child may have got the otitis media with conjunctivitis, and that means this child is suffering upfront from the non-typable HIV. And here is the situation will be, we will go for the amoxicillin. Now, if the child is less than 2 years, if the disease is severe, and at any given age, if there is otorrhea, when the pus is coming out, I think antibiotic is going to be there.
Right.
If the child is less than 2 weeks, the antibiotic therapy for the 10 days. If the child has some craniofacial anomaly, the antibiotics may be from 10 days to 14 days. And if the child is immunocompromised, I think 10 to 40 is very, very important. So, similarly, if the child is more than 2 years, disease is unilateral, there is
No
no
need to-
otorrhea,
No
and
need
the
to give.
symptoms are mild, here observation policy is more important. And within 48 hours, if child is not improving, or if the child is worsening, you will add to the antibiotic. And then again, the drug of choice remains the amoxicillin. If there is persistent otitis media beyond 48 days, you will go for the amoxicillin.
Right. So Abhay bhai has very well clearly mentioned about when to start antibiotic, which antibiotic, and how long this antibiotic is to be given. And we all need to, because again the AOM is a one condition which is very commonly mismanaged. Either in a fear or in apprehension, the antibiotic is started, or it is given for a short period. So we need to learn this and keep it in mind that there are very clear indications. The antibiotic should be amoxicillin as a first drug. It is, yeah, Abhay bhai.
And there are now new formulations for amoxicillin. 14:1 is available. So in majority of the situation, at least for Indian scenario, the dose
No need.
remains the 40 mg per kg.
Yes.
This 14:1 ratio is mainly required when we use the high dose, that is 80 milligram per kg, where you got the moderate or high level of penicillin sensitivity. So in this situation occurs in very few situations. And the
Absolutely.
common is the persistent severe otitis media in a child which is less than 2 years, where chances of local as the intracorneal complications are very high. In that case, you have to take care of the biofilm. And to take care of the biofilm, you will have a higher dose of
Higher.
amoxicillin, that is 80 mg per kg, and a small amount of clavulanic acid will take care of the side effects. So, with a less side effect, taking care of the biofilm with a higher dose is the, I think, is the drug of choice. So, we have a very
Yeah.
limited option as the 14:1 formulation is concerned.
So absolutely, again, there are some pharmaceutical company, they themselves are also highlighting about their product as a and the double dose. But as rightly said by Dr. Abhay bhai, the standard dose is effective in majority of the conditions cases, and the drug resistance issue is not that common in our country as of now, luckily. So we have a third case, a 2-year-old male vaccinated in the government setup, 8.1 kilogram weight, fever for 2 days, difficulty in breathing since 1 day. There is a vomiting 3 times, mild cough since 2 days, and not able to take feed well since last 1 day. Child is looking ill, febrile, tachypneic, tachycardia is there, SpO2 is 92, chest retraction there, bilateral craps, liver plus. Rest of the clinical examination is normal.
Yes, sir.
So, and this was the X-ray, and these were the basic investigations, the CBC. showed 10,600 counts, CRP 32 and volume of 68%. So Naresh bhai,
sir.
what is the X-ray? You have already got the X-ray. So now
So
you know
you-
that this is a pneumonia. But so what is the likely?
Sir, yes, sir.
Huh.
Yeah, good morning, sir. And the clinical history, looking to the clinical history, child is a 2 year and weight is low, so malnourished child, and high grade fever, difficulty in breathing, vomiting 3 times in last night, that is in 12 hours, and even refused to take pills. That is also not a good sign.
Yeah.
So if we look at the symptoms, child is going toward the severe type of the pneumonia. And
Absolutely.
if we see the clinical findings, the ill-looking child, sick child, temperature is significantly high, respiratory rate is more than 40 per minute at 2 year above age child. SpO2 is also dropping. It is less than 40, 94% at room temperature. It is also significant. Respiratory distress is there because chest retraction is there. All other things are also favoring to the severe type of the pneumonia. This is a clinical view of my.
You
So
will
I have to admit this child.
You will admit this. Child.
I have to make the patient in house. Yeah, in hospital. And then I have to investigate accordingly.
Investigation તો થઈ ગયા છે
Yeah,
આપણી પાસે છે.
So,
હવે બીજું શું?
first my step, I have reassessed the child.
Hmm.
SpO2 is 92. So monitoring to the SpO2, I have to give oxygenation. IV lines should be started. The rest of the sample has to be taken.
કયા
And
કયા?
I have to start the antibiotic, and correction of the dehydration is also important. So my
Antibiotics
My first choice will be in this child is amoxicillin.
amoxicillin.
Yeah,
Okay.
I have to start IV amoxicillin.
Why we should start with amoxicillin? Why not ceftriaxone, or why not with
Because it's a very short history
cefotaxime?
and this is a community acquired pneumonia.
Right.
So most likely organisms will be streptococcal pneumonia or a streptococcal pyrogen.
Yeah.
So they respond well to the amoxicillin and
Yeah. So again, this is a very old slide. I have been learning this slide for last 20 years. Very wonderful slide where depending on the different age group, you have the different organisms which are likely bugs. So you need to start empiric antibiotic thinking based on what could be the likely organism. So you are, as he said, that as pneumonia is one of the common possibility. So we have to start with the, Abhay, but you want to add?
And also, only thing is looking at the seriousness of the child, I think amoxicillin will be a little less powerful.
He said amoxicillin. He said amoxicillin.
Sorry.
He said amoxicillin. So I think it's a right choice. So again, that one message is that because this is a child who has a difficulty in breathing, the child who has a difficulty in feeding, tachypnea is there, not able to maintain the saturation, it is a case of severe pneumonia. So don't try to treat this case on the outdoor patient base. That is the first message. Second message is based on this age group, the common bug is S pneumonia. So you will start here because you are starting on a inpatient base. You will be starting with either this thing. You can start with coamoxiclav alone, and then if required, you can go to the third generation cephalosporin, that is ceftriaxone or cefotaxime. There are certain clues from the predisposing factors which can give us clue about the probable etiological diagnosis. Like if the patient has a history of pyoderma, or if there is a recent history of measles, think of bug like staph. If it is a patient is showing neutropenia, think of gram-negative infection. If it is a severe PEM case, again gram-negative or staph. So again, we just do not need to take the symptoms in consideration for the diagnosis, but we need to correlate it with all other history part. So the past history is also very, very important. Similarly, based on the clinical presentation also, you can probably think of what could be the bug. Like staph, you have a very young child, there is a rapid spread. So the patient who was well in the morning and by afternoon the patient deteriorates, and by evening the patient develops pneumothorax or pneumatocyst, think of bug like staph. So mycoplasma, again, a grown-up child, dry hacking cough is there. There is a myalgia or conjunctivitis is there. Then think of, so based on clinical presentation also, though you don't have the microbiological diagnosis by laboratory, but you can predict what could be the etiology, and based on that, you can choose your empiric antibiotic therapy. બલદેવભાઈ, સાહેબ હોય એટલે સાહેબને તો થોડો ગૂગલી કેસ જ રાખવો પડે. A 4-year-old boy admitted with fever, respiratory catral is there for last 5 days. He has developed today morning respiratory distress. 5 days થી fever છે, respiratory catral છે, અને આજે એને respiratory distress થયું છે. On examination, patient is febrile, tachypneic, hypoxic, subcostal retraction there. Patient is hospitalized. Oxygen inhalation start કર્યું છે, IV line start કર્યું છે, fluid start કર્યું છે. હવે antibiotic સાહેબ આપવાની કે નહીં આપવાની?
I think before I respond to the case, let me recollect this, I will say, with this Bhavnagar city. I remember that in 92 or 93, with Madam Desai and Rajubhai, we were there, I will say, with a very senior pediatrician, Dr. Raol's place. I was junior person and we had probably to go for dinner at some other place. Sir asked me that you can drive the car. You can drive the car because I was most junior person. I said, sir, I don't know the driving. Even Rajuvi was not ready to go for the driving that car, which probably we are not accustomed. From that day, probably we have visited, sir, your town several times, particularly myself and Dr. Rajuvi probably more than 8 to 10 times. And from that day, I observed that Bhavnagar had changed like anything, like any other
Absolutely.
town in the state of Gujarat. So I thought that let me, and second thing, the organizing team has probably played their best role for organization, that this was not the midterm,
It was,
probably not term or annual. This was beyond that.
sir,
and that
this is a post-term
Yeah.
actually, because the Bhavnagar is organizing after 19 years. So post-dated એટલું બધું થઈ ગયું છે.
Yeah,
અને હવે જલ્દીથી ભાવનગર ગુજ પેડિકોન કરે તેવું અમે જોવા ઈચ્છીએ છીએ.
yeah, certainly. So I thought that for the whole organizing team and particularly the pediatricians of this town, beyond this, even the office bearers of Gujarat State Branch, let me appreciate and express a word of gratitude and appreciation for all the team members who have really worked very hard. Now coming back to the case assigned to me, that here 4-year-old boy, please remember that tachypnea is a very sensitive and reliable sign for the diagnosis of pneumonia as a clinician. Even to our paramedical people, we can explain and here and therefore count the respiration rate for full 1 minute. If it crosses this particular limitation for that age and comes as a tachypnea, consider that it is pneumonia. With that, in drawing and sounds, define the severity of this pneumonia. Here, if we come back to our case, if the child has respiration rate 60, SpO2 is not maintained, 84, and even these all in drawings and sound. So I will say it's not just pneumonia, it's a severe pneumonia, and therefore it requires I will say indoor treatment. Choice of antibiotic point of view, still we know that it's a community acquired pneumonia, but with the severe requiring the hospitalization. Erythromycin is not, I will say, the macrolide, the drug for this pneumonia, as a even as the outdoor. Amoxicillin, yes, it's a drug of choice, particularly the outdoor.
But not in IT.
Amoxicillin, particularly with this, if you are suspecting that even difficult organism or even the staph might cover in this there, Ceftriax or its best one. Clocks again probably very specific for the staphylococcal. Meropenem does not require.
સાહેબ
And
આટલું
no
બધું
idea.
હાઇપોક્સિયા છે, આટલું બધું
And therefore in
patient-
this patient, yes, hypoxia is there.
પણ મેરોપેનમ આપવું
Community
પડે ને.
acquired. So that's why I will say rather than amoxicillin, I will go for the ceftriaxone in this patient.
Okay.
Looking at the severity of the patient.
સાહેબ
Meropenem does
ઓસિટામિવિર આપો કે નહીં?
I am coming to the point. Meropenem does not mean that any severe problem is going to be tackled with that. ask the questions to yourself, which organism you are targeting.
Absolutely.
What is the source, I will say, whether it is from the hospital or from, then look at the host. If it is really immunocompromised or something, that scenario is different. Here, host is competent, it is the source is community acquired. Yes, it is the pneumonia, severe pneumonia, but certainly I will rely upon the ceftriaxone. Probably I may not try for the amoxicillin. That should be the, I will say, good answer to this scenario.
સર એન્ટીવાયરલ આપવાનું કે નહીં આપવાનું પ્રેઝન્ટેશન વાયરલ ટાઈપનું છે આનું
Yeah, as I
હોસ્પિટલ
said,
કેટરાલ છે 5
all
દિવસથી
of us
છે
know that it may start with some viral also, but later on with this deterioration. And second thing, even in pneumonia, we are not sure, we will not be able to differentiate are they viral or the bacterial. Culture positive only 10 to 15%. So I will not even rely as we are discussing for other infections. Therefore, any pneumonia, viral or bacterial, once you diagnose, it should be treated with the appropriate antibiotics. And here, looking at the severity, I will go for not amoxicillin, not amoxicillin, but I think the ceftriaxone.
ઓકે સો
Sir, just
Huh.
one. Sir, being an ICU person, here on presentation, saturation was 84. I would be very cautious in next 24 hours because this may child may deteriorate very fast in next
Absolutely.
24 hours. So adding vancomycin at this stage is 50-50. You may add vancomycin at this stage also because primary, some influenza-like illness followed by secondary deterioration.
So that's
yeah.
what I was asking, sir. Could it be
Steph.
primary viral infection with then secondary staph infection?
I think as very rightly Manish said, suppose if the patient is deteriorating after the hospitalization, if you are watching, even don't wait for that, you can go for addition. Somebody starts even, I will say, as the looking at is the hard heat, and for that you
Then
can start this
de-escalate.
vancomycin to that extent. Once you come to know that yes, there is no problem, and even the vancomycin can be de-escalated.
Okay.
But
So
I will say both the ways if somebody is doing, I will say it's fine.
right. So the patient was hospitalized, ceftriaxone was started, investigations were sent, X-ray showed a huge opacity on the right side, CRP was raised, total count 22,000. Next day, again, child was not maintaining the saturation, means he was maintaining the saturation with O2, but still was running high degree temperature and still remained dyspneic. And so repeat chest X-ray was done. Almost you can say not a big difference, no other like pneumatoceles or any pneumothorax. A bacterial culture was sent and it came out to be MRSA.
So I think I was following the first, I mean, the theory.
Yes,
and I
sir.
may start with the ceftriaxone. Meanwhile, now the blood culture has come, and even the patient is not improving much or not showing any sign of improvement. With the MRSA, yes, how I will add this vancomycin.
So હવે આમાંથી બદલશો કે એડ કરશો?
The reason is, you know, that if the patient is vaccinated for the pneumococcal, probably streptococcal, I will not bother much.
Right.
Second thing, H influenza, again, if the
It
vaccine
is almost
probably
gone.
covered. Then the question comes, but still, I will say, I may not, as Dr. Manish saying, the PI should in the patient is there. Rather than omitting, I may start using ceftriaxone vancomycin combination.
Right.
Somebody starts again even the vancomycin, he is bold. I will appreciate, but probably as a clinician, I may not.
હવે
But not the gentamicin.
હવે સાહેબ તમારી અંડરમાં નહોતો ભણ્યો આ માણસ એટલે એણે વેન્કોમાઇસિન જેન્ટામાઇસિન ને રિફામ્પિસિન ચાલુ કર્યું. હવે બીજું શું કરી શકાય મનીષ? હજુ પેશન્ટને ફીવર રહી છે તો
So, expected time of improvement is usually 48 to 72 hours after starting the antibiotic.
right.
Here, child is persistent having symptoms of fever and tachypnea, so some complications, secondary complications should be there.
Right.
So, at this stage, focus that is point of care
Bedside
ultrasound will be the
USG.
best investigation. People go for CT thorax, but remember, CT thorax will have only advantage if it is chronic empyema or ancestor effusion. Otherwise, USG chest is much more sensitive, much more easy to perform in your ICU. So better to go for USG chest
And
rather
you
than
have
going for CT.
bedside
Yeah.
and there is no radiation exposure. And then again, if you have, if you see the collection and if you want to put the tube, then again you get the idea where to insert. While CT, there will be radiation exposure. So, okay, USG was done. The patient's respiratory distress continued. The repeat counts were done. Repeat chest tube was also inserted. Repeat chest X-ray showed little improvement, but not that great improvement. Abhay bhai,
So before answering this question, I think we have a clear-cut MRSA.
MRS,
The
yes.
bug has been isolated. I think so. There is no point in continuing septic. That is my personal choice. I would rather go with the vancomycin.
Vancomycin.
And looking at the toxemia and the septic child, I would add a clindamycin because the vancomycin is a bactericidal drug, excellent
Right.
penetration in the lung alveoli, and is a workhouse for the MRSA, at least it's invasive disease, because the child is bacteremic. Second, the clindamycin will take care of the toxin. And on the toxin, the staphylococcal organism produces a PVL, that is
Yeah.
penton valentine leukocidin. So this child is probably a PVL producing CA-MRSA. We
Right.
don't have any risk factor for the hospital-acquired infection.
So
So
what
we
are
are
the
dealing
risk
with a
factors?
CA-MRSA PVL toxin, and the drug of choice will be vancomycin and clindamycin. And remember, this is a bacteremic child. Blood culture is positive. So you need to continue the therapy for at least for 4 weeks. And
Absolutely.
taking care of the source control means a proper drainage of the empyema is very, very important.
Very, very. Yeah. Yeah, Baldev bhai, very quick comment.
I think it's such patient of the MRSA when you are looking and patient is not improving and deteriorating. Just look at even the CBC. And if there is falling of the count and neutrophils particularly, think that this PBL is playing the role. The very classically the leukocidin, that means leukocytes are destructed by this
By-
toxin. And that's the time to add this, I will say, clindamycin.
Clindamycin, right.
Second thing, between the choice of in the practice, what happens, linezolid and vancomycin. In any patient with a toxemia, with a systemic infection, linezolid even is inferior to the vancomycin. Please don't believe that this linezolid is the final answer. In that situation, vancomycin, although it is bacteriostatic, it is the better choice and the best choice which we should not miss.
Abhay bhai, very quickly, because I have still
So
three
if-
more cases.
If it would have been MSSA, then again there is no vancomycin. So
No
vancomycin
vancomycin,
is
yes.
quite inferior as far as MSSA is concerned.
MSS है तो શું ચાલુ કરતે તમે?
Doxycycline or cefazolin, yeah.
Cefazolin.
Plus clindamycin, yeah.
That is also very important message. MSSA, if you have the culture positive, vancomycin is inferior to even the cloxacillin.
Yeah.
Even
So-
the cloxacillin
Your
is very basic
cefazolin
drug.
is your very, very effective, but only thing is that somehow we people are not inclined toward using that molecule. So I think we will skip these two questions related to the PVL and antibiotic therapy. And I think Abhay has already said that you need to give a long-term 4 weeks antibiotic therapy. We move on to case 5. The still 5 months old male, exclusively breastfed, grown well, fever for 2 days, high grade, and patient કહે છે બહુ તાવ ભયંકર તાવ આવે છે ચીલ્સ હવે આટલા નાના છોકરામાં ચીલ્સ તો પણ એમ કે ધ્રુજે છે નોર્મલ ઓન એક્ઝામિનેશન પેશન્ટ ઇઝ હોસ્પિટલાઇઝ ફોર જીટ્રીનેસ કે કદાચ કન્વર્ઝન પણ હોય કે એવું તેવું અને પ્રાઇમરી ઇન્વેસ્ટિગેશન્સ આર ડન સો total leukocyte count 21,000, urine shows plenty of pus cells, blood culture sent, urine culture sent, and ceftriaxone is started. Blood culture is sent and blood culture turn out to be ceftriaxone ચાલુ કર્યું છે પણ રેઝિસ્ટન્સ બતાવે છે અને સેન્સિટિવ ટુ મિરોપેનમ. સો મનીષ આટલું ચાલુ કર્યા પછી પેશન્ટને તો 48 અવર્સમાં તો રિસ્પોન્સ આવી ગયો, એક્ટિવ થઈ ગયું, પ્લેફુલ થઈ ગયું, ફીડ લેતું થઈ ગયું, એ ફેવરેલ થઈ ગયું. હવે કલ્ચરમાં સેન્સિટિવ આવ્યું છે તો વોટ વિલ યુ ડુ?
So, sir, here culture shows E. coli that is probably SBL positive
Yes.
because it is resistant to ceftriaxone. But the child has responded, so there may be sometimes in vivo and in vitro,
vitro.
difference you may find in UTI. But if the child is responded, we'll continue with the same antibiotic. But the same moment we have to remember this child may have chances of recurrence UTI after responding to your ceftriaxone. So keep a
Absolutely.
watch after that also. But right now we'll continue with ceftriaxone only.
So again, this is a very, very clear message which we wanted to convey to the audience that there are different in vivo and vitro sensitivity. So don't just go on changing your antibiotic based on your report. આપણે ઘણીવાર કહીએ ને કે પેશન્ટને ટ્રીટ કરવાનું છે, રિપોર્ટને ટ્રીટ નથી કરવાનું. હવે ભાઈ કંઈ એડ કરવું છે નહીં? ઓકે, આઈ થિંક વી વિલ skip about the management of UTI in this because I want to cover all the 7 conditions which is common in the community acquired infection. Case 6, 7-year
The
old
only thing after treatment of the UTI, 4 months old child,
was
don't miss.
એનું USG ને એ
Yeah.
કરીને એને ઇન્વેસ્ટિગેટ
That
કરવાનું
is
છે.
very important.
એને ઇન્વેસ્ટિગેટ કરવાનું છે. આપણે સાહેબ અહીંયા ઇમ્પેરિકલ એન્ટીબાયોટિક ની વાત કરીએ છીએ ને એટલે પેલી બધી વાતો અત્યારે યુટીઆઈ મેનેજમેન્ટ ઉપર નથી લેતા કારણ કે એ કરવા જઈએ તો આખું ટોક યુટીઆઈ ની થઈ જાય. અચ્છા 7-year old high grade continuous fever for 4 days, no localization, child is toxic, febrile, physical examination is unremarkable, and patient has been on cefuroxime for 2 days without any improvement. Sahib,
I don't know how he got this safe Hiroxamine, the treating pediatrician.
સાહેબ તમારી પાસે નહોતો આવ્યો.
Anyway, please, can you go to the first slide? I think here 7 years old child, already Dr. Digant has mentioned that 4 days 5, 4 days duration and no localization. But they always first try to even categorize the fever. Here, I think category is there, fever without the focus.
Without focus.
Why category? Because the categorization will guide you that what next you can do. Here, once you define, then it's a duration of fever is less than 7 days. It's without focus. That means here, probably suppose I was waiting for the antibiotics or next action. Now is the time to take the action.
Yes.
Not only the, I will say paracetamol or some antibiotic we can continue. What we can do, I think we can try to define this clinical possibility. Here, 7 years old child with fever without the focus, first possibility to me is enteric fever. And for that reason, I will go for suppose CBC, if somebody has not done in the past.
Right.
But on the contrary, I'm sure that might have been in once or twice. Take the blood culture, that is very important.
Very, very
before
important.
starting the antibiotics. Even somebody has started already the antibiotics, still go for the blood culture. But please don't go for the typhoid dot or Vidal on 4th or 5th day, even on the 7th or 10th day. Because now all these serological tests are not useful, confusing to you. Best answer is to go for the blood
Blood
culture.
culture.
Blood culture probably, as I'm getting some argument, is not costly. Compared to our, I will say, mismanagement with the costly antibiotics, it is cheaper. It gives the correct answer. It guides me very appropriately. Therefore, blood culture, if I consider clinically that with enteric, if the patient is stable, I can treat as the outdoor. I will start the cefixime 20 milligram per kg per day.
Yeah.
And if it requires, suppose,
Hospitalization,
hospitalization, then I will start the
ceftriaxone.
ceftriaxone 100 milligram per kg per day, divided in 2 doses as the IV
Infusion.
over 45 minutes to 1 hour, and wait for the culture and response to the patient.
Right. So again, we wanted to convey the message to the audience that whenever you are dealing with a fever without focus or fever without of unknown origin, when you don't know the bug, before starting the antibiotic, always send the culture and consider the local epidemiology where enteric fever or the salmonella typhi infections are very, very common. Start with either oral cefixime, or if hospitalization is required, you can start with the ceftriaxone. And there is no role of combination antibiotics therapy for the salmonella infection. Again, ઘણા બધા લોકો જોડે બધું એમિકાસિન પણ આપે, so it has no role. Please remember. Okay, last case છે નરેશભાઈ તમારા માટે. 20 months old boy, rash on the face, and another small infant with bullous pustular lesions on the thigh as well as lower abdomen.
Sir, this is the first case of 20-month-old boy, rashes on the face, and there is a crust-like multiple lesions around the mouth and the nose.
Right.
This is very sensitive area, and this is a dangerous area also.
Mm.
The commonest organism causing this kind of the lesions are Staphylococcus aureus and sometimes Streptococcus pyogenes also.
Right.
So this is a impetigo of non-bullous types,
Okay.
where I have to treat locally as well as oral antibiotic also, and looking to the local site,
Right.
right? And the second is a bullous type of the impetigo. The commonest organism is Staphylococcus, and
Right.
very this self-limiting also, and the local treatment will be enough to treat.
So કોઈ પણ ઇમ્પેટિગો હોય તો ક્યારે તમે સિસ્ટમિક એન્ટીબાયોટિક આપો કે
If
બધામાં
the lesions are multiples and around the oral cavities, how much deep it is there, how much
Okay.
lymphangitis, lymphadenopathy is there,
Right.
if they're developing cellulitis type of the lesions, then we have to treat with the oral systemic antibiotic.
So basically, for most of the impetigos, you can just treat with the topical applications. Systemic antibiotics are indicated only where there is a widespread infection or a perioral region or where there is a deep involvement, then and only. Conclude કરીએ છીએ. Last જ છે message, one take home message છે. I think, yeah, one take home message from each one of you for the audience.
Yeah. So, sir, as sir has said, first see the host, think of organism, and then write your prescription. That will be the first message.
Okay.
Yes, sir.
If
If-
it is, I will say fever without focus or anything, always, whenever the possible, take the culture. Either the blood culture, urine culture, CSF culture. I tell my students anything from the floor even, but send for the culture.
Culture, okay. Abhay bhai,
All fever does not warrant use of antibiotic. We need to assess the child.
great.
If I am sure about the clinical condition, this is the viral infection, then I have to put the diagnosis in the infection, viral infection,
Yeah.
then there is no need of the oral
I think
antibiotic system.
this reminds me of Dr. Ambedkar sir to make a habit to write the provisional
Viral.
diagnosis, and the moment you write viral fever, it will shake your hand in writing amoxicillin or any antibiotic. So always make all these habits. I think our experts have already justified their role. They were really very crisp and very clear in their answers. Though because of the time constraint, we could not complete the last case. But I think the audience, we have passed on the very clear messages. Thank you so much for the opportunity, and thank you so much the experts.
એકાદ મિનિટ કદાચ આપની લઉં. અમદાવાદની અંદર હું ભણ્યો અને અમદાવાદના આ બધા સ્ટોલવર્ટનો મને અનુભવ છે. કોન્ફરન્સમાં અને એકેડેમિક પેલા તરીકે સાંભળેલા છે. બહુ વિદ્વાન છો એમાં કોઈ સવાલ જ હતો. પણ હું એક આપને સારા સમાચાર આપું કે જેમ ક્રિકેટની ગવાસ્કર પછીની ટીમ, એની પછીની ટીમ, એની પછીની ટીમ, અને હમણાં રિસન્ટલી એ ટીમ આપણી બદલાણી, એમ અમારા ભાવનગરની અંદર એટલા સ્ટોલવર્ટ પેદા થયા છે આ સબ્જેક્ટ કે તમારે રિપ્લેસમેન્ટ કરવું પડશે એક યા બીજા દિવસે, આજે નહીં તો કાલે કરવું પડશે. આ નરેશ ગોહેલ છે, બહુ પ્રેક્ટિકલ માણસ, અને અમે સિનિયર હવે રેસના ઘોડા, અને હવે એર કન્ડિશનની અંદર બાંધી રાખે, જયપુરની અંદર ઘોડા બાંધી રાખે. જે નવા સ્ટોલવર્ટ છે એની અંદર મેહુલ ગોસાઈ આ એરેન્જમેન્ટ કરી આપ જોઈ શકતા છો કે આ મીટમ છે કે આ એન્યુઅલ કોન્ફરન્સ છે એવું લાગે. એટલે અને સિટિંગ એકોમોડેશનથી માંડીને ક્યાંય ભૂલ આપણને જોવા ન મળે. એક આ 15th એઓપી જીએસ મિડ ટર્મ સાયન્ટિફિક મિડ 2016 ફૂલ કાઢો કે ભાવનગર કેમ નથી લખ્યું? બહુ એમાં કઈ ભૂલ જેવું હોતું જ નથી. ભૂલ જેવું હોતું નથી, ભાવનગરમાં જ છે. એટલે ધ ડે વિલ કમ that આપ આપ બરોબર બધા છો, અને અમે તો રિટાયર્ડ છીએ. એક વખત આપણે સામે બેસવાનો વારો આવશે અને આ લોકો આપણને આઈપીએલ રમતા હશે ને એવું લાગશે. થેન્ક યુ વેરી મચ. થેન્ક યુ.